Hi everyone, this is Aurelie Najm reporting live from Vienna at Eular 2024 for Now. There is a super trendy topic at the minute, which is pain. It is unfortunately has been an issue for a lot of people living with arthritis, experiencing pain, and sometimes it's very difficult to treat specifically, as there are many different mechanisms for pain, and some can be related to inflammation, and some aren't, and we don't have really good drugs for that, and so. There have been discussions as per whether some biologics or targeted synthetic DMARDs could be better than other in addressing pain and pain in its different mechanisms, whether it's nociplastic, nociceptive, and so on. And so there's a couple of abstracts in that aspect that looked into that more specifically. The first one is OP0072. And that study was the Select Compare study. So it was a randomized control trial looking at upadacitinib versus placebo versus adalimumab. And so what they did in this study, I think, was really smart, is that they separated specifically um, different type of the effect of the drug on pain, and they call one of them the indirect effect that is measured by surrogates of inflammation, which would be swollen joint count, ESR, CRP, but also what they call the direct effect, which is more related to either pain specifically in the patient global or the number of tender joints. And by doing that, they looked at 26 weeks and they compared upadacitinib, placebo, and adalimumab. And what I found really interesting there is that, first of all, we see that both upadacitinib and adalimumab do reduce pain as early as 2 weeks, which is great. And that's mainly through indirect effects and inflammation control. And in terms of control of inflammation, both treatments, adalimumab and upadacitinib, were similar in how they improve pain. However, when they looked at the direct effect on pain, looking specifically into the tender joint count, they were able to show that upadacitinib showed an improvement of that aspect twice more, 2 times greater at weeks 12 and 26 than adalimumab. And so that is suggesting that there might be something in the JAK-STAT pathway that is related specifically to pain, and it could be through the nervous system. It could be, there are people studying that at the moment and looking into what are the specific mechanisms for that. But that's definitely something to follow up on. And that is leading us to the second abstract, which is OP0086, which was a study called Be Real, RA Real study. And that study looked, it was an observational study this time, prospective, for 3 years, looking at people with RA treated with baricitinib or any other biologic and targeted synthetic DMARDs. And so what they looked specifically at there was the association of pain in the context of remission or low disease activity at 3 months after starting a new treatment. And they compared the baricitinib cohort, the TNF inhibitor cohort, and then this third cohort, there was a bit of a mix of everything, receiving either other targeted DMARDs or other mechanism of actions. And so what they looked is that the improvement of pain, and so they were looking at those people that improved their pain by 30%, 50%, or 70%, basically. And so what they show is that those people that were treated with baricitinib, while there was no difference in the achievement of a 30% pain improvement amongst group, there was a difference, percentage of people achieving an improvement of 50 or 70% was 67 and 46% in the Barry group, while it was 57 and 41% in the other mechanism of action group. And so what it's showing, it's a different way to look into, achieving pain improvement, although it's not looking specifically at the different types of pain. It's also telling us that there is some form of difference in how Jack, in this context, Barry improves pain, but I think it's a general Jack inhibitor effect rather than a specific compound. And that's kind of encouraging, and it makes me wonder, and I don't know if something that you do already in your practice. I actually don't, although we do think about it, is shall we obviously in the absence of contraindication and so on, prioritize JAK inhibitors in these people that have very, very strong pain component in their rheumatoid arthritis. So that's definitely something to keep in mind and maybe to look further into. It's now time for me to get back to the conference, and I will make sure I report anything else I find exciting for you guys later. Follow me on Twitter at Aurelie Romo, follow Rum now, and I'll see you around.